Okay, well, thank you so much to everyone for joining us and taking time out of your evening. I guess if you live in Asia or Europe, probably joining us at a very difficult time of the evening or early morning to be with us for this important webinar. We are proud to host this as a joint activity between the Northeast Ohio Liver Alliance and the Liver Coalition of San Diego. These are two grassroots organizations that have similar regional and strategic goals that aim to improve the lives of people with liver disease. My name is Pierre Gholam. I'm a professor of medicine at Case Western University School of Medicine, and I'm very proud to be the president of the board of directors for Neola. And I guess the best way to summarize Neola would be to tell you what our mission statement is. Our mission statement is to promote liver health through education, advocacy, and research, and to support persons living with liver disease in Northeast Ohio. So definitely a decidedly regional bent. The Liver Coalition of San Diego, which happens to share an executive director with Neola, Scott Succo, who is really a driver of many of these important activities. Thank you, Scott, for all you do. Has a mission statement to save lives by improving liver health and preventing liver disease through community-based education, linkages to care, advocacy, and research programs. So both laudable goals that are very much worth getting behind. I am joined today by a very distinguished panel of experts, advocates, and stakeholders, and hoping to have a very robust discussion, which very much includes your input, your questions. I see many experts in the field, many patient advocates, many folks who are very much involved in the area of steatotic liver disease. So your voices are not only welcome to be heard, but very much a component of this. Before I introduce our panelists, I'd like to thank both EchoSense and Madrigal for their support of this activity. I think your commitment to educating about steatotic liver disease is not only welcome, but necessary. And I'd like to thank, of course, Scott Succo, our executive director, Mark Abbott from Neola, and Aisha Kazim from Neola for putting this together. Our panel today consists of Dr. Rohit Loomba. Rohit is the chief of the Division of Gastroenterology and Hepatology at the University of California, San Diego. And I would add a member of the Medical Advisory Council of the Liver Coalition of San Diego. Rohit probably does not need much introduction in this field. He has made many seminal contributions, both on the diagnostic and the therapeutic sides, including most recently a New England Journal of Medicine paper related to therapeutics. We are delighted to have you here, Rohit. Thank you so much for joining us.
Your pleasure is all mine. Thank you for having me. Appreciate it.
You are welcome. Donna Cryer is the founder and CEO of the Global Liver Institute. I was trying to figure out a way to describe Donna without getting too lengthy. And I think the best way to describe Donna is that she is a force for good. I think that's a good way to describe her. And perhaps the best way to describe GLI would be to read verbatim their mission statement. To improve the lives of individuals and families impacted by liver disease through promoting innovation, encouraging collaboration, and scaling optimal approaches to help eradicate liver diseases. Thank you for joining us, Donna.
Thank you for having me.
And last but not least, Naim Alkhouri, a good friend and honorary Clevelander, always will be a Clevelander, and actually a member of Neola, even though he lives and works in Arizona. Naim is the Chief Medical Officer and VP for Academic Affairs at Arizona Liver Health, but he wears other hats in Ohio, including working and seeing patients at Northshore Gastro and being a part of the research arm of that practice, the Clinical Research Institute of Ohio. Naim is also the newly named co-chair of the AASLD task force for steatotic liver disease. More on that in a little bit, but thank you, Naim, for joining us, and welcome to the discussion.
Always a pleasure to be with you, my friend, and thank you for having us and hosting this important webinar.
All right, so thank you. So much of this will not be didactics. We're not here to lecture or talk about this in much detail, but a fundamental framework for the discussion involves telling you about this new scheme that was rolled out by ASLD and EASL at the recent EASL meeting in Vienna. And this is shown on your screens here. Formerly fatty liver disease is now referred to as steatotic liver disease, or SLD for short. And this is a spectrum of entities. Most of these are terms we're very familiar with, but that have changed to reflect the new nomenclature. For example, what we used to know as NAFLD, non-alcoholic fatty liver disease, is now known as metabolic dysfunction associated steatotic liver disease, or FAASLD, I guess. On the other end of the spectrum are people who have fatty liver, but do not necessarily have metabolic dysfunction. And it is not entirely known why they have fatty liver disease. And these patients are now referred to as having cryptogenic steatotic liver disease. There is I think, an important distinction that was made to account for patients who both have metabolic dysfunction and also consume alcohol, either moderately or in excess. And this is a spectrum that ranges from persons who we generally consider to be drinking above what is a hazardous, in what is a hazardous range, 140 grams of ethanol or 14 beverages per week for females, and 21 beverages or 210 grams of ethanol per week for males. These would be patients who have MET ALD, so metabolic dysfunction associated liver disease and increased alcohol intake. And of course, the higher the alcohol consumption of the patient, the more one would classify them as having predominantly alcohol-related liver disease, or ALD. And this is shown in the graph right next to FAASLD. There are people who have no metabolic dysfunction that we can discern, and these continue to be referred to as having alcohol-related liver disease. And last but not least, there is what we know as specific etiology SLD. These are patients who either have drug-induced liver injury known to cause steatosis, certain monogenic diseases like lysosomal acid lipase deficiency, Wilson disease, hypobeta lipoproteinemia, inborn errors of metabolism, genotype 3A hepatitis C, malnutrition, celiac disease. All of these are known conditions that can potentially cause steatotic liver disease and have a specific cause. So this is a more elaborate iteration of what we used to know. And I guess the purpose of this is the why and what's next, right? That is pretty much the focus of our conversation. I will also let you know that this has garnered a fairly significant societal buy-in. This is a non-exhaustive list of societies that have endorsed this new nomenclature. By the way, including NEOLA and LCSD that are not listed here. But certainly many prominent patient advocacy, education, professional organizations, GLIs listed there, have endorsed this nomenclature. So now that we have said that, I think we should turn to our panel and go over some questions related to the change and its purpose. And I will start with Donna. In your mind, why was this nomenclature change needed? I think that's a question people are asking. And I'd love for you to comment on this from both a patient advocate and provider perspective.
Absolutely. Thank you for this opportunity. I also, realize that this webinar is a perfect example of why the Liver Action Network that GLI convenes has come together and functions so that local, national, international issues can be discussed. And so all of the organizations named are part of our Liver Action Network. And so I'm very excited to say that. So my perspectives come from my background in law and public relations and business, as well as my time here in hepatology. What we were seeing was a divergence in the field of some areas of the world adopting different ways of describing NASH and NAFLD, and the confusion that it would cause if that persisted was deemed by all, I think, really undesirable. And so I really applaud AASLD and EASL and eventually other medical societies for coming together and saying we needed some type of process. And so the why is that so we wouldn't be fighting this out in journals and confounding the efforts and priorities that we have, and I believe we all share, in having drugs developed and approved and moving the field forward. Now, having this consensus doesn't mean that everybody agreed on the final outcome. In fact, I think most of the people who are in charge of the implementation are folks who didn't have the same comfort level in the final outcome. But the important thing was that the liver community come together and all move forward in one direction together. And so that's why the timing, while perhaps not opportune, was felt as necessary to stop any further fracture and division within the community.
Rohit, your thoughts from a clinician and researcher perspective?
I think it's really important that we understand the implications of where we are. Changing the name appears to be very simple, but when you have a change with a new definition, it really requires us to really see if the natural history remains the same or not. It will really come along as we think about FAASLD as what it is. And it's not just fatty liver, but it's also at least one metabolic risk factor. And I think as we were looking at some of the cohorts that we had in the past, changing the inclusion-exclusion criteria in many of those studies would mean that we may have to define or better define the natural history of disease. So there is a lot of onus on all of us who are here, stakeholders, to really better define the natural history of disease and also keep it still intact for drug development for those who were previously classified as at-risk NASH, that is NASH with stage 2 fibrosis or higher. And in this nomenclature, it will be MASH with stage 2 fibrosis or higher. And I think at least for that subgroup of patients, there should be a lot of similarity and the natural history should remain the same. But I think we still need to document some of these things. And that's what is the biggest challenge and an opportunity for all of us to come together. So I'll just start with that. Thanks, Pierre.
Great. And Naim, your thoughts on why the change was needed?
I think we've known for a while that the term NAFLD, non-alcoholic and fatty, they're stigmatizing. I think we knew that also the use of non-alcoholic doesn't really help with describing the pathophysiology of the disease. So we knew that a change was needed. Again, this was a democratic process. We did this Delphi process. We had 4 rounds of voting, 264 experts that were representative of most geographic parts of the world. And we all agreed, there was a super majority on most points that we need a new name. We heard from patient advocacy groups that the word fatty was stigmatizing. And to put this into perspective, obviously there was a change that happened before around 2020 where the term MAFLD was being used. And MAFLD meant, again, the metabolic piece was included, but the word fatty was still in the name, and that was stigmatizing. So we felt that steatotic is actually less stigmatizing for patients. But also the definition is different than MASLD because they did not specify the alcohol threshold. And we felt that this will create issues for biomarker development and also drug development. If you actually change the definition, now you have a different patient population. So in addition to changing the name, every effort was placed to make sure that the MASLD population is almost identical to the NAFLD, historic NAFLD population, and the MASH, at-risk MASH is similar to at-risk NASH, so we don't affect the drug development and biomarker development processes. And there was actually an external validation in the Litmus network showing that, with the new definition, about 98% of the patients with the definition that we have now for MASLD will fit the old definition. So it'll be no change basically in drug developments or biomarker development. So I think we had, several reasons why we needed a name change. I think the timing was maybe pushed on us a little bit because of the other definition that was being, proposed, and we started to see it in the literature. And we needed to make sure that the definition did not hinder the efforts to develop new biomarkers and new drugs. So I think all these factors were, important in the decision to do the name change, and then how we ended up with MASLD.
Great. Naim, I'll stay with you. So you have the distinction of being a dually trained pediatric and adult hepatologist. And I think from that perspective comes the epidemic of steatotic liver disease in children. What do you think this change means for children? How would it potentially impact their daily care? And maybe we can take it a step beyond that research.
Yeah, no, thank you for bringing this up. As you said, MASLD is an issue in children, and we estimate that 5 to 10% of children may have MASLD. And if you look at adolescents, it goes up to 15, 20%. So definitely, this is a disease that we see frequently in pediatric GI and hepatology clinics. I think, I felt the issues with the old nomenclature with NAFLD every time I had to sit down with a 12-year-old and say you have non-alcoholic fatty liver disease. And they always had this look on their face like, okay, thanks for telling me I'm not drinking alcohol, but I'm 12 years old. So I think, that was important to change it in pediatrics, and it's been an issue for a while. And I think the word fatty also has been very problematic, especially in teenagers where, they may have other, body image issues. And to use the word fatty was really not a good way to communicate the nature of this disease. So I think the name change has been needed in pediatrics for a long time. I think one of the issues that was brought up by many pediatricians and pediatric hepatologists is the use of metabolic dysfunction, because there is an existing entity of metabolic liver disease. And there are some concerns about, the MASLD, nomenclature may be confusing some people, especially, patients, families, if they Google metabolic liver disease and, trying to distinguish between metabolic dysfunction associated steatotic liver disease and metabolic liver disease caused by inborn errors of metabolism, other genetic liver diseases. But I think, that puts the burden on us to do more education for patients and doctors that are not in GI hepatology to make sure that they understand the difference. But yeah, this is my take for pediatrics. I think the timing for pediatrics is actually better than adults because we're still at the infancy of biomarker and drug development. We have several studies looking at biomarkers like transient elastography and MR elastography, but we don't have really validated thresholds. We're getting there. So I think,
Sure.
Changing the name is not going to affect that. And same thing with drug development because the trials are just, getting into the pediatric population. So that's in a way a good timing for the name change in pediatrics.
Donna, thoughts about the name change and how it impacts children?
Well, certainly it was very important to me. And in full disclosure, I am married to a pediatrician, pediatric geneticist. So it's always in the forefront to me. But that opportunity or that potential for confusion, because metabolic right now does refer or has been used to refer to pediatric conditions. And so we recognize that one, it was very important to involve pediatricians and pediatric gastroenterologists and hepatologists in this process to help work this out. I think that's one of the reasons why we ended up going with a term like steatotic, which, you know, Latin may not be optimal for everything, but it was something that was able to bridge with our pediatric colleagues. And I think Naim is right in the timing of all of this. There will be less impact on our work with pediatric populations simply because it's less advanced. So a lot of the momentum that we have with the NASH terminology in adults and policymakers and others, which will take a little bit of a setback, really won't in children, because we were only just beginning there and have the opportunity to introduce this new nomenclature as if this is just the nomenclature to be expected.
Rohit, your thoughts about the name change in children?
I think with children, I would say still there is complexity in the sense that explaining things to kids, particularly those who already knew that they had fatty liver and now they have some other problem. And even explaining to existing patients who have, you know, fatty liver, and then when they come back that they don't have fatty liver. And so explaining that, I think there is a challenge. It's best to acknowledge it. And that makes it easier and humbling when you explain it to the patient. So I think I'm not going to minimize that there are issues that we face every day when you're talking to a referring provider, whether it's pediatric or adolescent medicine or adult medicine. And they call, so what's with it? This patient with fatty liver said, no, don't call fatty liver. It's called steatotic liver disease now. And so what does that mean? And at the end, I say, oh, it doesn't mean anything, it's still the same. Then they really get confused. So I think embracing and acknowledging that, I'm sorry, it's going to cause a little bit of confusion, but I'm here to answer your questions. Same thing is happening with kids who, you know, typically would be seen. And then, as you know, as they enter their college years, for the next 6 to 7 to 10 years, they don't have a physician visit. So there is a gap for patients who come back when they're 27 or 28, that what they heard from their pediatrician back then is very different for you know, from that and what you're going to say to them now. I think just acknowledging that and understanding and appreciating that it is an issue, and it would be important to continue to recognize that and say that they may ask, what is steatotic? And at the end of the day, it's still fatty liver disease when you explain it to the patient.
Right.
If I may follow up on that, I think Rohit is exactly right. And when we've been extensively polling our NASH Council, which is over 80 different members, the patient advocacy community vary, and the consensus is leaning that we're just going to have to talk about fatty liver disease, because however you peel back the layers and whatever words you use, you still need to explain to someone that they have more fat in the liver that is healthy for them. And so, the issue of stigma for the patient population was sort of 6 of one, half dozen of the other, not something that was enough to drive change of this level of disruption, because for as many people as didn't like the term fatty, there were more who really found the nomenclature around non-alcoholic to be helpful to explain to their family that no, this isn't because of alcohol, because it's really the liver disease itself at this point that's still stigmatizing. And so, I have primary sclerosing cholangitis. Doesn't really mean anything. You have to tell people it's scarring of the bile ducts. And so I think likewise, steatotic liver disease will never really mean anything to real people. We'll have to tell them you have fatty liver disease.
Great point. By the way, we have truly a world-class panel of experts listening to us, including many pediatric hepatologists. So if you have thoughts, interjections, questions, please feel free to type them in the chat about this or any other topic. Rohit, I'll stay with you, and I guess you touched on this to some extent, but let's take it a little bit further. Do you foresee changes in the way we conduct clinical trials and research in this area? Does this impact inclusion exclusion? I think you mentioned this a little bit in your previous comment.
I think, Pierre, you're right. Again, I foresee that it will have a change. It may not change the outcome that we're looking for drug approval from, Subpart H or long-term approval for clinical outcomes for complete approval. But I think it will have an impact on probably better quantification of alcohol use, which is already happening. We're using PET more for assessing liver disease. It is also bringing, I think, MET ALD, which is people who drink a little bit more, but they're not to the extent of alcoholic liver disease, and they may have significant fibrosis. What proportion of our patient population falls into that category is not fully, described. And we would think, sitting on this side, that that's a very big population. But when you start looking into your own database and going back, it's a much smaller population. So maybe we need to think about this patient population that has stage 2 fibrosis, stage 3 fibrosis and cirrhosis, maybe a little bit differently. And all that patient population that's currently in MET ALD would actually potentially be candidates for treatment once therapies become available that are exclusively into, MASH with stage 2 and stage 3 fibrosis. And studying this population, I think, becomes now really important. And it is up to us as stakeholders to start having therapies be tested in MET ALD population as well. And then alcoholic liver disease with a clear quantification now, I think probably more attention will be drawn to that as well, and probably earlier stages than alcoholic hepatitis. So I think we're going to see more research across the spectrum of alcohol use in patients with steatotic liver disease. That'll be a game changer.
Naim, thoughts about this, and maybe specifically talk about MET ALD, because that's clearly it's not a novel concept, it's a novel definition. Do you foresee research focusing on that subset of patients, perhaps designing clinical trials to be tailored to them?
Yeah, I mean, I completely agree with Rohit. I think this is one of the most exciting development for me as someone who conducts clinical trials and help pharmaceutical companies design protocols is the MET ALD category. We had to exclude these patients in the past, but you knew that they had the type 2 diabetes, obesity. You knew that their steatotic liver disease was driven by metabolic risk factors, and maybe the alcohol was contributing, but I always felt that it's not right to exclude them from NASH trials, and that they may benefit from the same mechanisms of actions that we had in our typical NASH trials. So I think I'm looking forward to understanding this. I think we have several databases that we can utilize to understand the disease burden of MET ALD. We need to understand its impact on the requirements for liver transplant. I think we need to understand also the performance of biomarkers in this patient population, because we know, for example, something like FIB4, AST is going to be affected by alcohol consumption. So we need to really understand the accuracy of the biomarkers that we're utilizing, and then the effects of drugs. And, a new thing that's happening now is medications like semaglutide. It's been shown to decrease alcohol cravings and potentially intake. And, they're being tested even for alcohol-associated liver disease. So I think this is very exciting. I think, the science has always to lead. So, we changed the name, we changed the definition, but this will have other implications, and AASLD has an implementation plan that will be announced, and several conversations are happening now with the FDA, for example. So for drug developers, are they going to change their application to using the new nomenclature? How does a label look like for previously NASH drug or MASH drug? Conversations are also happening with the NIH, and that may affect also the pockets of funding and where the funding is coming from. So a lot is happening on the research front for sure.
Donna, this interface of alcohol-related liver disease and metabolic dysfunction-associated liver disease, is that going to be something that we need to talk more to patients and stakeholders about? Do you see anything that's necessary for that specific subset of patients?
Absolutely. I think that one point of agreement was that if we were going to go through this arduous process and this level of disruption, that we needed to create a nomenclature that could evolve with the science, so that we weren't at the same place trying to think of new names a year or two from now. And so I think that is one of the benefits, that we have expanded the categories and also made this rather more reality-based, if you will. That the reality, as Naim said, was that many patients with some level of alcohol use were being excluded from trials previously. And so now we can have trials that more accurately represent the real lives of patient populations, and as Rohit said, be able to get them treatment. And so I think that it is a positive step to have created more defined opportunities and areas of research that include rather than exclude the diversity of patients within this spectrum of disease.
So Rohit, in addition to doing the research, you also take care of patients, and it's been a couple of months now since this was rolled out. Have you had conversations with patients? Have you said, Mrs. Jones, you have steatotic liver disease, and they looked at you funny or something, and you had to explain what that meant? What's been the reaction and the feedback from patients?
Yeah, I think it comes back. I'm still keeping a bridge from my previous conversations, and that bridge is really important for those who've been followed for many years in our studies. So because they know what their diagnosis is. The new patients is much easier. I do still talk to them about the reason they're referred. So typically, I'll start the visit that. I'm Dr. Loomba, one of the liver doctors. They already know that, but I still explain that to them and then say, your Dr. X, who I share a lot of patients with, referred you to me because they found that you had fat in the liver or your liver enzymes, ALT and AST, were elevated, and they've been elevated for so long. So I kind of put that framework in front, and if it is related to imaging that led to this referral, then I start from that there and then explain to them about their disease, and particularly if they fall in the MET ALD category, then I think utilizing the new nomenclature is very helpful, and patients do get that better. Those with FAASLD, I think it requires a little bit more time with them than previously, for sure.
Naim, let's focus on a new patient. Someone sees you in the office for the first time. You diagnose them with somewhere on the spectrum of SLD. Have you had conversations, and how have those conversations gone in terms of explaining?
Yeah, I mean, I use the new nomenclature mainly in younger patients that I felt, avoiding the word fatty will be beneficial for them, especially if they're not coming with already a referral that says fatty liver disease. I mean, many patients, they come, they know they have a fatty liver sometimes, although it's a new patient for me, they've been told they had fatty liver for years and years. To be honest with you, Pierre, I'm not stressing out about using the new terminology with every patient. I mean, someone gave me this example. It resonated very well with me. They said, when you have a myocardial infarction, your cardiologist is going to tell you had a heart attack. And, no matter what the science is, you want to say something that the patients understand. I think, the way I say it, I'm trying to use it more now. I say the new terminology is steatotic liver disease. It used to be called fatty liver disease because many patients, they want to go and Google stuff and get some, resources, and they're not going to find much on MASLD. So, I just explain it and I tell them why we changed the name. And I tell them, stigma is a big deal for these patients, but also you have to make them feel comfortable that, obesity should not be stigmatized, having type 2 diabetes. So it's not just the liver piece. And I think this is our job as providers. So, when this was announced, I had a meeting with our staff, and we have different pieces. We have a marketing department, we have the research department, we have the hepatology clinic. And as a group, we decided to hold off on implementing this on a large scale until January of this coming year. But we're going to start doing it in a gradual way. And I think it's okay. So we're not stressing too much about using SLD. The last thing I want to say is in terms of ICD codes also, you cannot really generate in the EMR something based on ASLD or MASLD at this point. Worried a little bit about billing. So we're taking it slowly. But, the only thing we're changing is mainly in the notes now. We're putting the MASLD terminology, things like this. But again, it's going to take time. And I didn't want to stress my entire team about absolutely using the new name from day one. I think ASLD is recognizing this, and they realize it's going to be a process.
Donna, what's been the feedback from the patient community about the new nomenclature? What have you heard or sensed so far?
Not all of it is printable in a family newspaper. So we followed, we decided to just have the same type of pause that Dr. Alkhouri's practice have, that, we announced very early on that we would not be using the new nomenclature until we've gone through a transition planning stage, and sort of set at least until Labor Day. After Labor Day, we would come back before the community with a plan. The best practice for any type of name change of this type and magnitude would be to have set, as Naim did, that on such and such a date, the name will change. And the work that's done before the name is changed, which had been our recommendation, are these conversations that are happening now with NIDDK and FDA and others to make sure that we understand the impact and the implementation, and that we can ameliorate any harms that this disruption caused. Now, so we're not in the best position of having had that lead time before change, but I think sort of common sense, people are now creating that time and that pause to do that work. We had recommended and bring in those other types of expertise, whether it's from communications or market research or business, to understand the finances. We certainly have received from many different organizations, patients and others, line item forms that we've helped with on going through the impact on their website, on the materials. For GLI, we have national materials in 18 languages. So each one of those materials will have to be redone and then retranslated. So being able to be very granular and precise, and I look forward to the opportunity later this week that Naim and Mazin Nuruddin and the ASLD have created for us to start to present this information. Although we get one slide, and I have like Santa Claus lists of naughty and nice lists of things that will be implicated. One of the things that I had said early on that was mentioned here was the ICD 10 and 11 codes, some of which we had just gotten NASH changes integrated into, will not match, do not match this nomenclature. And so to have patients who have a piece of paper that says one thing and a code that says something else, and then to hear out in the in the conversation in the ecosystem, something else is confusing. And so the need for a bridge, and I think that's really a wonderful metaphor, to have these bridging conversations that you may have heard it discussed like this. We're now using this terminology, but at the end of the day, this is what it means for you as an individual. But we have to do that with payers, with regulators, with EHRs. There's a very long list of places that this change and this impact need to be brought all the way through. And certainly my wish and the wish of the patient advocacy community, some of whom may not be viable, honestly, after this name change. We're trying to help support that and make sure that they stay up and running. But our wish was that there had been a definitive time for a transition before an announcement was made.
Fair enough. Rohit, so I'm sure you think deeply about this. If we were to go and look at the nomenclature and beyond, and if you had a wish list from a public health standpoint, from a clinical implementation standpoint, what would your wish list be to advance this field forward?
I think my wish list would be that there is a clear coordination between all key stakeholders, the societies, AASLD, AGA, ACG, connecting with CMS, Centers of Medicaid, developing the ICD-9 codes, 10 codes and 11 codes, matching all of them appropriately, and with FDA updating their guidelines with changes in the nomenclature adopted swiftly, and same thing happening at NIH and future RFAs. And I agree with Naim and Donna that this could be, we could say, okay, let's do everything by January 1st. People are always saying, oh, that's too fast. Look, it's already upon us, so now it's our responsibility. And I think things can be done if people really get to work. And it's basically a lot of editing and then thinking through each question that comes up. So that would be my wish list, that complete alignment, from physicians, clinicians, societies, government and government agencies, funding agencies, and FDA.
Naim, how can we move this field forward? Nomenclature and other things.
So many things. I mean, obviously, I think the biggest unmet need is having, effective FDA-approved medications that we can utilize in at-risk patients that may progress to cirrhosis. And, eventually the dream is to be able to treat even patients with NASH cirrhosis and be able to reverse their disease and decrease the, progression to decompensated liver disease that may require liver transplantation and, liver cancer. So I think these are, my long-term wishes to really change the natural history of this disease. And I think, as Rohit said, alignment is a very powerful word. And if we can actually align and work together, I think, good things are happening. So we think that potentially next year we may have our first FDA-approved medication. We think that there is momentum now to potentially shift the design of clinical trials from relying on histology and liver biopsy to utilizing non-invasive testing. I think the natural history of the disease is becoming more defined. As I mentioned earlier, my excitement about the MET-ALD category, and also designing clinical trials for patients with ALD, but not acute ALK-HEP, more the patients that drink 6-7 beers a day, and they progress slowly to cirrhosis. So I think many good things are happening, and I think, change is difficult, but I think at the end of the day, maybe it was a good thing that we made this change this year in 2023. So moving forward, 2024 would be the year of MASH and FAASLD with new drugs and new NITs and great momentum going forward.
That's a perfect segue to a question that Dr. Gerberding is asking. The speakers covered some aspects about the potential impact of the new nomenclature on NITs and drug development and regulatory pathways. Can you, all three, comment about why representatives from industry and regulatory authorities, aka the US FDA, or not involved in the nomenclature change process? Maybe we'll start with you, Rohit.
Yeah, I think it's really important. I would say that it's never perfect. I think they try to include a lot of different people. Getting FDA or regulators involved is tricky. You know, many times we would send invites and they're restricted to have their own opinion. And at these, a lot of opinion is individual. So, you know, I'm part of the nomenclature group. Each time the question is posed to me, it's individual, my opinion representing my team. I think it's very difficult for regulators to have that kind of, you know, opinion. And so I can understand the regulatory aspect of it. And so probably that's why they were not in it. The industry, I think, is important. And I think it would be definitely, you know, important to hear their viewpoints. One issue sometimes comes is that, is this independent of any financial conflicts? And so, you know, most of the other stakeholders, you know, declare their conflicts of interest. And so I'm not saying whether it's right or wrong. I'm just giving you reasons why it becomes difficult when societies are involved. Even when we are setting up panels to write guidelines, why are industry stakeholders not invited to write those guidelines? So there are reasons that they have a financial incentive in it. And so it is likely that those reasons led to why the choice of people on the stakeholder list was created. I'm not defending how it was done or why, but I'm giving you some reasons that are potentially possible, you know, answers to the question that was raised by Julie. Thank you.
Donna, thoughts about regulators and industry stakeholders being involved in naming and beyond, right? I think that's the question here. Yeah.
Absolutely. So it's the reason that the GLI NASH Council does have industry at the same table as physicians and patient associations, so that when we come out with positions, they are fully informed by all the different stakeholder groups. So I took a very big responsibility in terms of clarifying statements like out of the Chicago meeting and making sure that all of our industry partners were aware that this was going on and had the opportunity to inform my views along with patients and physicians that I was listening to. So my statements are more well-rounded on behalf of the NASH Council as a whole. And so that's why, you know, I really felt that these conversations with FDA and EMA and others needed to happen before a name change was finalized, for just the reasons that we're seeing, that it was insufficient. You know, there was a Delphi question about, do you think that the FDA would do? I was like, well, are we really going to bet the whole farm on what we think they're going to do? Shouldn't we ask and have a greater level of certainty before we move forward? And so those were the recommendations that I have, because our processes at Global Liver Institute really are informed by all stakeholder groups. And so I think also with the legal hat on, if industry were quiet in some of the settings where they were invited to, I can just imagine that their compliance attorneys and departments were telling them really to be rather neutral, since this is typically a thing that medical societies and physicians, have, whole control over. And so, would have probably been given advice, I certainly would if I were in a compliance role, to not speak publicly. But certainly in other venues, it was very clear how nervous this was making people, as it might delay drug development, require biomarker revalidation, and that the cost of changes, imagine if OCA, for example, had actually been approved, they would have to go through a label change at this point that costs over $1 million. And so there was a lot of the implications and costs of this that would be borne by industry. And so to not have them a part of some compliant part of the process is not best practice, I'll just say.
Naim, you get the last word on this. What are your thoughts?
I mean, I think this was a scientific process, and the science is leading the way. And obviously, there's a whole implementation plan. These conversations are taking place. So, of course, it's great to have everything lined up from the first minute you make the announcement. But I think it's also normal to have the physicians, the researchers lead the way, and have the science make the first move, and then we follow on all the other fronts, whether it's FDA or NIH or pharma or the World Health Organization or even ICD-11 and moving forward ICD-12, where hopefully the new nomenclature will be implemented. So I think there's no perfect world. Ideally, yes, I would have loved to have everyone aligned. I think even the name, obviously, not everyone who was part of the process agreed on it, but this is democracy and this is what we have. So I think, again, there's no perfect world, but this is, I think, was a fair process. And I think I'm happy with the outcome. And I think more changes to follow and the implementation plan will be announced and will be clear how we're going to move on all these fronts.
Okay, well, we want to be mindful of folks' time. This has been a fantastic discussion. So one last question to all three of you, maybe to end on a note of optimism, I hope. So let's start with you, Rohit. From a diagnostic and therapeutic standpoint, what's the big picture in steatotic liver disease today? Where do you see us going? Are you optimistic about the future? If you look in a crystal ball, perhaps you have more insight than just that. Where do you see us in 3 years, 5 years, 10 years?
I think future is really bright and really brightest for our patients suffering from all varieties of steatotic liver disease. What the nomenclature has done is brought out not only what we were doing in NASH and atherosclerosis, but a whole spectrum of people based upon their alcohol consumption. And I think we will have new treatments, as Donna and Naim pointed out, will be coming across the spectrum of alcohol use, whether it's FGF21, whether it is semaglutide, GLP-1, a dual agonist, triple agonist, as well as other therapies such as FAASLD inhibitor, or ACC inhibitor, or thyroid hormone beta receptor inhibitors, agonists. So I think there are several therapies now that have shown consistently that you could reverse steatohepatitis. There are several therapies that show that you could improve one stage of fibrosis. And people do believe that these results are true and will be long-standing. And so we know, as the panel discussed, that there will be new treatments coming our way. So my take home would be that NASH is completely reversible disease. Fibrosis is a completely reversible entity. And we may be moving towards therapies that may start working in patients with cirrhosis. So that's really positive. And we were not at this level of certainty just a few years ago. And I am certain that new therapies for MASH-related fibrosis will be coming to our clinic in the next few years. So thank you.
Naim, I think Rohit gave us a nice overview of therapies. How about diagnostics? So I don't want to sound too controversial, but recent deliberations by the FDA reflected some skepticism of the role of NITs. What are your thoughts? Where do you think this is going?
Liver biopsy has been around for a long time. The disease spectrum has been defined based on biopsy, but now that we've been doing clinical trials, for a long time, we see all the issues with biopsy, the lack of agreement between pathologists on the presence or absence of NASH, even fibrosis stage. So biopsy definitely has issues. It is invasive and can be associated with significant bleeding, sometimes mortality. This is a common disease, and we need to move beyond biopsy. I think what we're learning every day with NITs. I think in terms of quantifying steatosis with MRI-PDFF, I think, we don't need further validation. I think we have several studies showing also the importance of decreasing liver fat on MRI-PDFF. We've had issues with the concordance between biomarkers. We learned that once you have multiple biomarkers pointing in the same direction, that the accuracy and the positive predictive value is definitely high enough that you do not need a liver biopsy. There will be be certain patients where the NITs have limitations and biopsy will still have a role, but in my mind, that should be definitely less than 5% of the patients that we see. But to design trials based on biopsy and to keep with this current regulatory pathway, I think is not the right thing to do. I do believe that within the next 3 to 5 years, we'll completely move away from biopsy, because we're also generating a lot of data showing the prognostic value of these NITs. So when the liver stiffness is high, whether it's on MR elastography or even transient elastography, this has a meaning by itself. And we cannot continue to ignore it because they don't always correlate with the biopsy. And we have similar data with the enhanced liver fibrosis test with FIB4. So I see that world. I think it's going to happen hopefully sooner than what we think. Skepticism is always good, but also we need to understand the limitations of the biopsy and just come up with something that is fair to our patients and drug developers and can help move this field quicker.
Okay, Donna, you get the absolute last word. What is the future of steatotic liver disease? Your thoughts?
It's very bright. It is, I'm highly optimistic. We certainly will have multiple drugs approved over the next several years that will have, very appropriate risk profiles. And I am really excited about getting beyond the biopsy. It's completely infeasible and impractical to scale to where we need to go to treat the number of patients with the spectrum of disease without using non-invasive technologies. I'm also very excited about AI, digital assisted histopathology, making the most of biopsy samples and moving us forward. I would also just to note that, beyond just the hepatology division, FDA has a new robust digital health services. And a lot of this also falls into CDRH, which moves at a very much faster pace. So I think for all those reasons and many more, there is a very bright and fruitful position for this field.
Great. Thank you so much. I'd like to thank our panel again for this fantastic presentation and discussion. I think we had a very thoughtful review of all the issues related to the nomenclature. Thanks again, Rohit Loomba, Naim, Alkhouri, and Donna Cryer for your time. Thank you to the many, many patient advocates, patients, experts, doctors who joined us today. We hope that you will join us again for future Neola and LCSD activities, and we hope you have a good evening. Thank you very much.
Thank you. Bye-bye.